We can start
Okay,
in the meantime, other people can also join.
okay, sir. Sure. Uh, Good evening, everybody, on this West Zone Psychiatry Society World Women Mental Health Subcommittee webinar on every third Friday. We welcome you all. Especially, I welcome Dr. Kshirod Mishra, sir. He is our uh, president, sir. Sir, welcome on this webinar. Today's topic is very interesting, and it is beyond stereotypes, understanding borderline personality disorders across genders. And none other than our expert in the field, Dr. Hema Tharoor. She is the expert speaker. Dr. Mishra, would you like to welcome the people and share your
Yes, ma'am.
views
I'll
on
just have a
this?
short welcome calendar. It not take much time. And good evening, everybody. Welcome, Hema Madam, and all the team members of the West Zone Women's Mental Health Subcommittee, and all the participants who have joined. I welcome you all, and we all understand the importance of borderline personality disorder in our day-to-day practice. So I'll not take much time in introducing, and I'll request Hema Madam, who is the expert in the field, and she can start with the permission of the chair.
Thank you very much, sir. Let me introduce Dr. Hema Tharoor. I hope you all can see her slide. I'm sharing the slide. Can you all see it?
Yes, ma'am, we can see.
Okay, Dr. Hema Tharoor, she is a senior consultant at the Apollo Spectra Hospital, and she has vast experience of 25 years. Madam has received many awards, and not to list a few, Dr. T.M. Pai Gold Medal for Excellence in Medical Research. Also, she has completed NIH Fogarty postdoc fellowship in ADHD, especially at Washington School of Medicine. She has contributed to other awards such as Dhruv Kumar Award for the best paper in the psychotherapy domain twice. She also has been faculty in charge in DNB training at SCARF and also a faculty at KMC Hospital and has more than 50 publications. She is a vociferous affirmative mental health professional for LGBTQIA community. Welcome, madam, and we are waiting for your discourse on this borderline personality disorder and how to differentiate between the presentations. They vary sometimes. The self-harm behaviors also vary, and many other behaviors vary across genders in males and females, and maybe the other gender also that you have the experience. We welcome you, madam, and it's over to you. Thank you.
Oh, thank you so much. And once again, is want to heartfelt thank you to the West Zone. And I think when Dr. Vidyut reached out, I was like delighted to talk today. And by borderline has been I think it's a pet topic for all of us. I think when we all may feel very frustrated, but at the same time, in sort of dealing. And over the years, I think all of us here combined, we will agree in practice that they drain us and they also help us, completely in terms of, in the treatment and how it's sort of, I just want to put in some pearls which have come up in research and clinically, how borderline and looking at borderline has evolved. Thank you once again, and thank you, President, for those kind words. So I'm just
Madam, your poll is there in the chat, and if you want our participants to go through it, you can.
yeah. Parallelly, I've just put some 5 interesting questions on. So if you can answer while you listen to me, I'm hoping all of you will multitask and just answer those questions related to how they present in front of you. Just want to start this talk by saying that, generally when they say, I mean, as a postgraduate, and there's just that general connotation attached, oh, borderline, it has to be a female. And the belief over the time, there is even epidemiological studies to say there is more bias when you look at the data. And all the diagnostic frameworks have historically emphasized only female presentations, sidelining the men. So there's a lot of bias, misdiagnosis, stigma, and systematically men have been ignored. And of course, when it comes to the minorities, they've been ignored further. So I will just pay a homage to our Bible and then get to. So DSM-5 and ICD 11 talks about the signs, abandonment, unstable relationships. We all know about impulsivity. Dr. Ritambra talked about self-harm. I think it's more of self-injurious, non-suicidal, self-injurious behavior heightened in them. A lot of emptiness, which now we see, a lot of anger, and diagnosis requiring 5 or more criteria. ICD-11 has gone on to, as we all know, right, has gone on to look at, more than a checklist. Uh, they've looked at severity and they've divided it into, I mean, very similar overlapping symptoms, but we all know about the EOPD, borderline specifiers to help us. So specifiers of borderline impulsivity and the instability. So I just wanted to put this here so that the criteria goes on to describe instability, but I would like to go on to latest ways in which the whole personality is looked at and clinically how it could apply to us in day-to-day practice. I I thought I'll bring in pop culture influences, and if you just Google just to emphasize how gender skewed it is, you'll see all these only. If you look at famous people, and of course, homage to Marilyn Monroe, and all movies would be female centric, highlighting BPD. So the diagnostic shadow has a lot been female predominant, looking at this disorder like that, and more showing how gender prevalence, and studies have shown that it is equitable, just that the selection of the sample, and this is where there is a strong emphasis on saying that biology, the brain doesn't discriminate, but over the time, right from the initial years, selection bias and female seeking help. So it has become like a female centric disorder. There have been studies to sort of validate what I just said, gender roles in male and female in patients with BPD. This was a very BMC article that came out, and looking at severity of clinical symptoms, which I'll allude to, in fact, how they were looking at men with borderline personality had more masculinity. They were comparing it with a control group, and they showed no differences in the way the clinicians perceived between male and female, and they were looking at gender roles, sex role inventory, and all was done in this study. I'll allude to the consensus of this work and other work in a minute. So the gender bias evidence, I want to reiterate, consistently shows clinical samples show female predominance, but it just is reflecting who's seeking help. So all of you sitting here, if you last 6 months, if you look at your clinical sample, you'll find that women have probably sought help much more in this personality paradigm than men. But community studies, there's no significant gender difference. I just want to highlight that than the actual prevalence. So our whole diagnostic trap saying that, women are more borderline, quote unquote, or women presenting with antisocial are always mislabeled rather as BPD and very rarely talked as ASPD. So just want to highlight here, clinical samples, help seeking bias has been skewed because it's more elevated in women, and so women are diagnosed more. Community studies, there's no gender difference at all. So how BPD represents in men and borderline doesn't discriminate the gender. And just want to highlight or stress here that men are always misdiagnosed or misunderstood as far as the diagnosis is concerned. And why it goes very undictated more and more is because, like I said, in clinical presentation, the differences, which I'll come to in a minute, clinicians' bias also, and variations in the treatment settings. So if you look at, I remember, a greater part of my years were in Manipal, Kasturba Medical College, Manipal, where we would see a lot of students, women seeking help more compared, for issues related to the above symptoms that I mentioned. And many, many a times that we would end up saying, oh, it would be a joke. Like during coffee time to say that, okay, access to a woman, is it borderline? So that you are already forming the diagnosis even before talking to the patient. While in contrast, men also display a lot of anger, antisocial behavior, substance use. The last 4-5 years, I think there's a cannabis wave. I think cannabis is easily available as gummies, and I don't have to go into it. But we are seeing equal amount of substance use across men and women. But to highlight problems in men, self-harm behavior, suicidality, and unstable relationships, and a lot of overlap between narcissism and the BPD connection, which I will allude to. So while we map clinical differences, so just to summarize what I said so far, the community studies or epidemiology doesn't differentiate. Clinically, we see it because of the help seeking. So internalizing symptoms are more common in women. And the thing is that the symptom expression follows very, very distinct pathways. So you see intense fear and abandonment in women, more of mood and eating disorders and PTSD symptoms in women, and more of externalizing, impulsivity, substance use, antisocial, a lot of problems with the law and in men. So externalizing symptoms in men. Again, when you visualize the gap, men highly impulsive, women highly suicidal, antisocial as a co-occurrence. I just mentioned PTSD as comorbidity. So the clinical blind spot, which I want to highlight, being male BPD often overlooked, while female anger is labeled inappropriate rather than a symptom. And why all this matters is unrecognized borderline in men leads to undertreatment, criminal involvement, and you can prevent harm for them. So we have the female pattern, male pattern, which I just said, males having explosive temperament, novelty seeking, impulsivity, and the female having the emptiness, internalizing, and chronic affective instability. Comorbidities also differ. Substance use more in men, and women having eating disorders and mood disorders and PTSD, like I said. So I've just put a snapshot of all the symptoms. The slide sort of conveys it, but nowadays we see a lot of ADHD overlap. So the RSD, rejection sensitivity, is very high. Emptiness people talk about, mentalization-based therapy. So they fail to mentalize. Alexithymia a lot. Depending on the intensity of the trauma, they report shame. So I wanted to just splitting, like we all know that they can be very hypersensitive, and splitting as a core feature in terms of what they feel. So just wanted to highlight this in one slide like this. So this was an interesting, like right from historically when borderline personality was evolved till date, what is it? What is borderline exactly? I just want to enter into now. This is a very interesting work in the last 2 years, identifying types of BPD based on the symptoms they're presenting with. So the petulant type is someone who's unpredictable, mood swings, very passive aggressive, and has a need to feel control. The discouraged or the quiet type of BPD is somebody who fears abandonment, is very dependent, clingy, needy, still has emotional mood swings. The impulsive type is very bingy, risk-taking, and aggressive behaviors. And the self-destructive type, which is very, partaking in self-harming and abusive behaviors. A lot of time identifying, if you all can remember the slide of petulant, impulsive, quiet, and the self-destructive, very, very important, because over the last 3-4 years, especially after COVID, now we are seeing people talking about overlap of ADHD, BPD, autism, BPD, so much of overlap of symptoms, which I'm going to present to you all in a bit. And just to highlight this, in the quiet, or which I just mentioned right now, symptoms don't manifest in a very overt way. They are very internalized, and many, many times the DBT therapy is very, very helpful for the quiet BPD person more compared to the covert one. So just alluding to the Black Swan movie, where this is an example of the quiet BPD. While primarily dealing with perfectionism and anxiety, this person has many traits with identity confusion, emotional intensity, and self-destructive behavior. So just to say that the presentation, looking at it from a clinical pattern, helps us a lot to nudge the person towards seeking DBT, and in the right time with the right therapist. So having said all this, I also there's a lot of movement to look at transdiagnostically, because we're seeing a lot of overlap of symptoms in mental health. And how do we look at BPD across genders, and if from a transdiagnostic way? So I just talked about how there is a lot of comorbidity, and men with BPD have higher rates of involuntary hospitalization and substance. So you'll have somebody admitted for de-addiction, and we are looking at it only from the de-addiction angle, and we'll just casually say there's personality involved, but it's very important to assess whether the male is actually having borderline personality disorder. And again, in women, we always see the whole anxiety, PTSD combination in them. Remember, I know nowadays social media is just like flooded with trauma stories, but it's very, very true, I think, from our clinical practice, that we see that about 70% of them have experienced adverse childhood experiences. I want to now navigate the talk into looking at transdiagnostic and how there's a lot of overlap. And so when you see an individual sitting in front of you, it's very, very important to look at their emotional regulation from all these angles. So complex PTSD and BPD shared features. Since the slide is visible, I just want to highlight on the share this history of interpersonal trauma, emotional instability, suicidal ideation, self-destructive, and depressive states. Now, overlap does not imply diagnostic equivalence, but just to remember, where we are looking at the individual patient, to recognize these things and understand that, especially if there is complex PTSD also involved, there's a lot of trauma-related dissociation, shame-based self-perception. Just keep this in mind. Now, I'm just going to highlight diagnosis in which nowadays, in the last 3 years or so, mainly, and especially, I think COVID has opened a lot of windows with people coming forward from, I in fact say it's an ADHD pandemic and adult autism diagnosis pandemic. So the whole overlap between autism and BPD, and a lot of autistic individuals seem to be, it is not common to see them being diagnosed because of similarities in emotional dysregulation and social difficulties. So it's very, very important that, to sort of see the overlap. And this is where I just wanted to highlight the overlap of EUPD, BPD versus autism. Again, alexithymia, emotions, so the emptiness here and the alexithymia, where autistic people report, the intensity of feelings and hyperfixation in under the autistic spectrum. In a bit, I'll show you a slide of overlap, which makes this more readable. along with this, so you have now BPD, ADHD, BPD, all the three having interpersonal difficulties, self-esteem being impacted, sensory symptoms, sensory processing, high rejection sensitivity, a lot of executive functioning difficulties, and a lot of genetic overlap, which I put this slide up to show that this is the person in front of you. You have somebody who comes to you saying ADHD, and sometimes they have self-diagnosed or gone to people who can diagnose, quote unquote, saying they have some autistic spectrum features. So all this comes to you, but I just want to show the slide more to convey the amount of overlap that you see in them. So in autism and BPD, what actually is the social masking, alexithymia, increased risk for eating disorders, executive function disturbances. And when you see this, it's very, very important to see how they overlap with each other. And many a times when you don't hear them out or listen to them, and thanks to Dr. Google, many of them walk away feeling more not understood by us. Again, this slide to show that was the overlap and what is very common between all of them in terms of rigid pattern. Like, remember I pointed out the petulant type and the quiet type. So the quiet type can have a lot of obsessive, rigid thinking. So it's very, very important to see how much is common between them. The other very, very common that we see is the borderline and the narcissistic personality. In fact, I get referrals sometimes saying borderline narcissist. Just to keep this in mind about manipulation and guilt from the borderline perspective, and how much of gaslighting and manipulation happens from the narcissistic perspective. So to just remember that, and I think all of you would agree, it's a deadly combo when both the traits overlap and there is a heightened sense of emotions that are expressed. I've been seeing a spurt of eating disorders across, and now thanks to the whole GLP wave, if I can say it here, we're seeing a lot of eating disorders, bulimia, risk of self-harm. Again, bulimic behavior is a self-injurious behavior, and about this study talks about as high as 53% in this latest publication from BMC. Just a small thing on BPD and bipolarity can co-occur, very different disorders, very important to recognize. And many a times it's the personality causing a lot of pathoplastic effect, which is more harder and challenging to treat. So what's the future here? Please discard the stereotype, adopt a very gender neutral approach. Biological and biology doesn't differentiate. Cultural influences we have to keep in mind. Longitudinal studies, 100% talk about, while the prevalence is same, they talk about gender diverse samples, and clinicians have to be trained to reduce their bias while they assess, especially the men. Clinical reality, remember, women often receive therapy, men are funneled into the substance use, right? And in the sexual and gender minorities, since I work with a huge amount of the LGBTQIA plus, it's like a double whammy for them, because they are dealing with a lot of issues related to their existence. And we do talk about how much the borderline person expresses that they are not understood. And again, with the minority, they feel they're completely validated to feel this way, given what all they experience. So they have a disproportionately higher BPD diagnosis, which conflates with their identity. And so the diagnosis and stigma is very, very important. And BPD remains one of the most stigmatized psychiatric labels. Interestingly, to share here, I had a male borderline person who said he made a tattoo to say DBT and BPD because he felt he had to wear the diagnosis on his sleeve. So we have to break the cycle, see beyond the gender, recognize the symptoms. I'm advocating here for equity and inclusive care. So in the trans diagnostic, before I sort of, take you all to the last part of my presentation, is I just want to, and for all the postgraduates listening into this, I feel that to look at this person more from the emotion, disturbed relationships, or disturbed relatedness the person feels, how discontrol they feel, and rather than operating it from the gender perspective. Can't run away from biology. So I just want to highlight that it does not discriminate. And the trans diagnostic framework, in a minute, it's a very interesting tripartite model of borderline. I just want to show that it offers a more accurate, equitable model for gender-based categorization. And I feel we should drop borderline label and treat the system that is involved and not the stereotype. So we are all acknowledging the biosocial theory of BPD, sensitive biology. They are vulnerable, highly emotionally sensitive and impulsive. There is an invalidating environment, neglect, trauma, criticism, expressed emotions, and then there is dysregulation. I'm sorry if it's not clear, but it's a very important paper looking at triple network model in BPD, looking at the default mode network, your executive functional. Uh, I'll share the slides are for sharing, so maybe then it's clearer. I think when I've made the slide, it's probably a little faint, but for just to understand that the default mode network, the executive function network, all the three, so the DMN pathway, the executive functional pathway, and the amygdala working in, if I can say, in tandem, causing or explaining the salience that they go through, explaining the hyper arousal that they feel and the intensity of emotions that they feel. So it's across gender. This is the same. So in the assessment gap, it's very, very important that clinicians often should apply a gendered lens and not have a bias. I'm like a mantra, I'm saying men are underdiagnosed and treated just as ASPD. The moment they have substance abuse, have had some run-ins with the law, it's ASPD and narcissism. The BPD is missed, and women are over-pathologized for their symptoms. Hidden variables being the sensory sensitivity, which I just mentioned now in the biosocial theory, social coping in women, because women will seek support, and the reactive expression in men, which is these are all, again, lived experience papers talking about, what men also go through. And so more often men, it is attributed to their character. And this is sort of accounting for the paper that I initially talked about, looking at gender roles and stereotypes. So let's challenge the life sentence. More or less, people who are in therapy, I liaise with a couple of clinical psychologists here who do excellent DBT work. There's one of them who runs a DBT group with very good success rates. And I've had even one of my person meeting me who ran he ran a very patient peer related group for a year and a half, which was also very, very effective. So I want to break the myth and say the facts. It affects both genders, and we should focus on the reaction. And of course, we acknowledge there is manipulation, but help them regulate their emotion and not look at it as, they are just dismiss them off for how they behave. So what most people think of BPD is being irrational, over manipulative, and emotional, but I think they are also highly empathetic, beautifully sensitive, extremely observant, and incredibly resourceful. So before I conclude, I just want to say, please, the central question should shift. not on who has BPD, but how the dysregulation represents in both genders and in the minority group, and what each individual needs. Personalize the care, adopt a very trans-diagnostic framework, replace this categorical list taking to more a gender. Look at the individual in front of you, dismiss the very gender-laden diagnosis, and look at it from emotional, behavioral, and relational systems. Integrate a very gender-informed practice and ensure that they have very equitable care. Thank you very much for a very patient listening, and I'm open to questions. And I put up a poll of 5 very basic questions related to how you view a person sitting in front of you. And I would ask Dr. Ritamra to take over. Thank you very much.
Yes, yes, that was a great discourse, ma'am, and I'm quite actually, positively looking at it that you are saying that 75% remission rates, and 6 years down the line, recovery is possible. Maybe with all the therapies, I think that if they go through, or otherwise also, ma'am.
Yeah, that study was more they're looking looking at inpatient hospitalization. So Mount Sinai, this person who is still meeting me, he conducted a peer support for a year and a half. I mean, he had in fact stayed in an inpatient setup for 3 months where they had intensive DBT. And I must say, so I've seen him when he was 14, when he first met me, and now he's a young boy, 25, and definitely he comes under that 75%. Yeah.
Okay.
So like this, there are many stories. So I think the good marriage that we can have with a very good therapist, and
Hmm.
and now because a lot of times we have to individualize, like this person after DBT now seeks help with somatic sensory therapy, and but I think the core is and now even some of them like to do mentation based work. So I think we should guide them properly and also check how they're doing in therapy. And I think the group therapy did a lot of improvement, you know.
Right, right. Uh, okay. Uh, if you can share some good case study, ma'am, and some of the tips that you can know. Sometimes, especially what we see in our OPDs, and especially with young PGs, they definitely have these counter transference when some self harm behaviors of these people come across in emergencies and all that. So, if you can give some tips, like.
So I think now with like what I just put out, where when we see if I can break this lifespan approach, when we see adolescents or late adolescents, sadly, screen addiction, the phone has become the proxy parent, what they're accessing. So a lot of time you end up having for want of a better word, a tough person sitting in front of you, the sense. So I spend the initial sessions are all in gaining trust. So for a young postgraduate, because they're highly manipulative and they can be, if they want to share, they will share. So, but the initial session is about their narrative, gaining trust. And I understand in a very busy OPD. Like if I could share my Manipal experiences, I remember Professor Sharma and me, we would after OPRs, because students would not want to be seen, quote unquote, in the OP against stigma. So we would actually see people after 5 p.m. and they would meet us, and then that's how. So I would encourage if postgraduates are willing to. Of course, patients you can't ask them to come after beyond the OPRs, but I think listening to, so the moment they talk about, let's say they talk about self-injurious, they fit into your checklist. um, but I think that rapport building, trust, and sometimes they want to talk, so I feel it depends on what they prioritize. It could be body image and eating. So even if you ask them what they're comfortable to discuss, so it's a journey with them, your relationship. And I feel because uh, a lot of time patients also may end up choosing. See, they do a gender bias. They will tell you they want a male psychiatrist or a female psychiatrist, even though
True.
both genders would make them comfortable. So I think
Mhm.
it's a marriage, and I think we need to spend time and patiently
Spend time, more
yeah,
time, and
yeah,
extra time, and quite separately
yeah.
one needs to. Yeah, that's true. A few comments and questions are there, ma'am. Dr. Nachiketa here, he is writing that in males with BPD, won't narcissistic traits be incongruent? Because he observes that low self-image of borderline traits versus high self-esteem, high self-image of narcissistic personality traits. So how
Yeah.
BPDs can have narcissistic
Yeah.
traits?
So, thank you, Dr. Nachiketa, for that. So this is that's why I put up that petulant, quiet. So in the what clinically is seen in the quiet borderline presentation is there is also a high, for want of a better word, self-esteem, achievement. But there is also, like I mentioned, about splitting. There is, self-doubt about what they have achieved. So the silent narcissist, or the no, I'm this question where you're asking about high self-image of NPT traits, you may be alluding to somebody who's a covert narcissist. There still the impulsivity or dysregulation can be explained by both because in somebody who's covert, uh, the depending on the addictions or what they want to in their relationships, it could be out there on your face. But I'm talking about the silent person, and having also the BPD traits. That is the person in which you will see high self-image, and equally have being split, and because they may have failed relationships. The silent narcissist is what I'm talking about, who presents as the quiet BPD. Yeah. Or the
Yes.
petulant BPD, very passive aggressive.
Mhm. If you can, ma'am, I mean, it's difficult, yes, but can you tell this case story of this quiet BPD, if at all you remember one case?
No, no, I can. So mostly the quiet BPD are people who will, on paper, are very high functioning, no self-injuries. They maybe even be scared of needles, knives. To
Mm.
a point, you will want to assess for is there OCD, OCPD, and things like that. They are obsessional, and they will talk to you about relationships. They would have a breakup, but they are obsessing repeatedly about the partner. Not eating. So it's a lot of withdrawn, not eating, not sleeping, a lot of anxiety symptoms. But when you explore, or if you call in the family will say that there's a lot of silent anger, not talking. And then when you dig further, the person will tell you that, so what I mentioned about neglect, perceiving neglect. This is the person I thought who would be in my life. Everybody leaves me. You will get a very good history related to this person completely withdrawing, neglecting, for want of a better word, some parts of their self-care, but will show up in office. So over the years now, we are seeing a lot of where, in fact, we call them silent. That's why, and I was glad when I came across the last 3 4 years these papers on the quiet. You will not even So, and the family will say that stubborn, very stubborn, not eating food. Um, and not to jump and look at it as eating disorder, but to, of course, they will show their behaviors more like that, but functioning well, functioning in the sense occupational functioning, or somebody is going to college, will clear the grades very well. But this whole thing about their be it the grief over a relationship, or they will tell you they are chatting on these dating apps multiple. They will say that I'm so upset that they will show silent anger also. I want to do this to another person, which could be self-sabotaging for them. Yeah.
So it won't be the overt behavior, but and sometimes internally.
Yes, so you won't see one typical cutting, multiple tattoos, multiple, substance use, nothing. But you will see them very, if I could use passive aggressive, high functioning. That is the
Mm,
key here. But and trust is a big issue with them. So only if they're comfortable, they will reveal this part. Otherwise, in
mm,
the initial presentation, you will think it's a breakup, relationship failure, and you may send them away. Only if you explore it, you get these features.
mm, mm, mm. Right. So, in continuation, Dr. Ankita, I think she's asking that can some cases of treatment resistant depression, sometimes people with depressive disorder are not responding well, and they can be actually undiagnosed BPD?
So, Ankita, you must make a clear distinction. Like I said, we see a lot of that RDD with. So, if I'll take just 30 seconds. See, right now, I have somebody who's on paper RDD. Definitely, I will say EUPD with, of course, some histrionic features, to a point that in April, she did so much of head banging and she ended up with a subdural hematoma. Okay. Drained the hematoma, and she refuses to go home. She says either she wants to stay in the hospital, and she's somebody whom, in my scarf days, I had admitted her just for respite for the family. So right now, I just admitted her yesterday back to scarf for a month. She says, I don't want to go home. Okay. So here, this person, RDD is there, very seasonal. The depression is more even bipolar in nature. She was, uh, and so do they overlap, or that is in the depressive episode? Sometimes does the personality factors have an effect on the depression? Yes, but you'll be able to clearly distinguish. So it is a dual diagnosis. I wouldn't say all that depression was personality disorder. Yeah. So you
Right.
must,
So, as a comorbid condition,
yeah, duality.
yes.
And I think Ankita's asked another question, I think, about.
Mm, okay. Then another question is, how does group therapy help in patients with BPD because of interpersonal difficulties and emotional instability, which could even play a role in the process? So, how group therapy helps?
Uh, so I think Kirtana's asked this. Kirtana, so
Kirtana.
what is done is just like in the ethos of any group. There's a lot of the shared stories which help, right? And one is, oh, okay, I'm not alone. There are so many of them going through the same thing. So what Dr. Kirtipai is someone who does this in Chennai, and so she does at least, uh, I think, roughly, I'm saying in an average, minimum 4 to 6 months of individual DBT work. Once they are at least more stable, all the four pillars of DBT, they are into it. And Kirti is also trained in trauma focused IFS. So if she needs to, she applies that also with them. And then they all go into group. I mean, you're inducted into the group, and the older members make the new members, comfortable. And so there is a lot of sharing. And I think Now she does it the last Saturday of every month. So this question where they've already done that core interpersonal effectiveness and all that, so it would really help them.
Right. Yes. Yes, and Ankita is again asking, among patients who achieve remission, what psychological change seems most responsible for recovery? That means for recovery, with what change is more?
I think, Ankita, 100% is them accepting the diagnosis, if I can say. I mean, the people who have said, okay, so this is what is happening to me. And also, we play a big role in normalizing them that this is their normal, right? A lot of time when they come to you, they're crying, saying, why am I not like the other person in front? I mean, somebody else. So, teach them that. And second is, I think all of them, I mean, if I can seriously joke here, they're all wanting affection and love. They all are like love. There's a So I think a stable partner and somebody, and I tell the family somehow, I don't know if all of you would agree, they end up, the B and C get attracted. So all the Bs get marry the Cs, and the Cs are very patient, and of course they have their issues, but yeah. So one is the insight into the diagnosis, regular in therapy. Uh, I think they are the ones who, so insight, they are able to attribute, and they come and tell you, I did the distress tolerance techniques and I feel much better, and you know, so I think that is the singular most. And many of them who are lonely, I think tend to lapse and relapse much more into their self-sabotaging behaviors.
Yes, some people are asking for the resources and some books, if you can suggest.
Yeah, so one, my big go-to is Stop Walking on Eggshells. It's very good for families, spouses. I had a couple of men who said, Doc, instead of Mangal Sutra, this should have been given to us. So it's a very, it's called Stop Walking on Eggshells. Again, I'm repeating, they can easily get it on Amazon, and very, very useful for the families. There are a couple of other books also. If you all just Google, I can put I mean, the authors, it's about lived experiences, but I feel, uh, I always tell, I mean, very honestly, after this actor Johnny Depp and his famous divorce, which was there's a lot of BPD's been, I think, because his ex-wife was, there were a lot of psychologists opining on her personality. So a lot of patients read all that and come back and then feel very upset about how pejorative it is about borderline women on the web. So it's very, very important to tell them, I always tell them, please don't read the internet, because when they read the after personality assessment, you have to de-escalate their anxiety related to the diagnosis. So, like Ankita asked, I think accepting that, is very, very important. Um, People have asked, somebody asked about pharmacotherapy,
Oh,
which,
yes, Dr. Truti is asking that.
yeah, Dhruti, I would say, I mean, I'm just also sharing. Cochrane highly recommends flupentixol. My experience, it works very well. I think a low dose antipsychotic uh, helps. So from flupentixol, aripiprazole, now a lot of them have issues with weight gain. So low dose antipsychotic, oxcarbamazepine if there's a lot of anger, mood fluctuations. I use a lot of naltrexone. I'm a big fan of naltrexone for non-suicidal self-injurious. This cutting, I want to also say here, cutting is also very addictive. So naltrexone adding on to this also helps a lot. Uh, Endoxifen in the last 5, 6 years, again, when you have, again, the borderline, substance use, impulsivity, endoxifen playing a major role. So it has to be individualized, all these medications along with DBT.
Yes, thank you. One is again asking some recommending books to understand therapy's role in complex PTSD. Oh,
That
that's
maybe
not.
I mean, yeah, if you can message me, I could. I mean, yeah,
Yeah, it's
offhand, I
not
think. See,
so.
with complex PTSD, I mean, if you can get some training in trauma-focused care, because sometimes EMDR techniques are used, and you know, to deal with the trauma separately, very, very important. Yeah.
And again, Ankita is asking the role of ADHD and executive functions in the development of borderline symptoms.
Yeah, so that's why, Ankita, I put up that
Yes.
brain slide on the executive function and default mode network working together 100% in the development. Yes, but like, and then you add, so that's why Reddit has devoted its columns to rejection sensitivity dysphoria in BPD and the RSD in ADHD. So if you have ADHD, BPD, the RSD that you see in people is extremely intense and high. Yes, I would agree with Dr. Pramod Purushottam about, yeah, Princess Diana. Yes, I wanted to put her photograph too. Yeah.
Any more questions? You can come alive on video. Anybody? Any of our subcommittee members? Dr. Vidyut just left. Okay. So many people are thanking you, ma'am, for excellent presentation.
Thank you.
And Dr. Mishra, sir, you can just come alive and talk.
No, no, madam, because I didn't want to disturb because let the people ask questions. We
Right.
have a lot of experience with this group of people, and most of the time we try to avoid them. But sometimes it
Yes.
may not be feasible. Not all time, not sometimes all time may not be feasible.
I
And so that is one of the most difficult area because many occasions we have burnt our fingers also while dealing with them. And one of the advantages actually they have got poor frustration tolerance. So if they don't like you, they actually sometimes shift you also. We have seen because dealing with this mainly these adolescents mainly in this medical college, we find a lot of issues here.
Oh,
So,
yes.
but we have to deal with them whatever best we can do. And there also one advantage is that poor frustration tolerance. So they change doctors also. So that is one
Oh,
of the
yes.
advantage. So this is
The
very good
rapport
presentation,
builds
madam.
very quickly and they change. Yes,
Yes,
yes.
they
Till
were
they
very poor
find someone
frustration. And
like Dr.
if they
Tarun.
find if they find something like they're not able to like match with you, they usually change. So
Oh,
that is one of
yes.
the advantage.
Oh,
And
yes.
otherwise, is the most difficult area to deal with.
Oh, yes, 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 yes,
Thank you
yes.
very much, madam, for the nice presentation.
Thank you.
Thank
Thank you,
you.
sir.
Thank,
Yes.
thank you, thank
We had more than 62 participants, ma'am,
you. Yes,
and
yes.
Thank you.
thanks to
Thank
you,
Very
I
good number, and thanks to all the
some
participants.
Thank you.
presentations, and very actively they have participated in asking questions and all. And we are quite enlightened, ma'am. Yes. Thank you. Thank you very much. So, can we call it a day, sir?
Yes, madam. Thank you very much, madam, for nicely coordinating.